Good afternoon, everybody. Welcome to Good afternoon, everybody. Welcome to this afternoon combined grand round from Department of Cardiology, Cardiothoracic Center. We are going to present today the work that has been done by the department, especially Professor Bhargav, in Mission Delhi, which is the Delhi Emergency Live Heart Attack Initiative. And this addresses a very important need. As you know, the heart attacks, the cardiovascular diseases following that, they are increasing and they are of great concern. And to address this important need, this mission was started. So I'll briefly talk about the acute myocardial infarction and the role of early thrombolysis, which is life-saving in these cases. So it's the common term, as we all know, is heart attack, and the main reason for this is the acute coronary occlusion leading to myocardial infarction, which is the muscle cell necrosis of the heart muscle. And the main therapy is reperfusion, that we have to open that artery again. And the main predictor of outcome is the time to reperfusion. So earlier it is done, the better it is, and therefore what is said is the time is muscle. So just to recapitulate the mechanism, this is the coronary artery. The atherosclerotic plaques they develop, they have a lipid core and they have a fibrous cap. And if they are non-occlusive, the blood continues to flow. However, in some patients, this fibrous cap ruptures and the underlying lipid is exposed to the blood, and this leads to formation of a blood clot, which suddenly causes an occlusive thrombus and cessation of blood flow to that part of the muscle. And immediately as a result, the patient gets severe ischemia and the muscle cells start to die, and the patient gets severe chest pain. So here, for example, in the right coronary artery, there is a plaque which has got acute clot, and this muscle in the inferior wall will start getting infarcted. So the patient is going to have severe chest pain, and unless this flow is restored, there will be a permanent damage. So here this is an angiogram of a patient who had presented to us, and on angiography we found that the left-handed descending artery had got thrombus, and there was a marked reduction in the blood flow to the branches. So time is muscle. Initially there is this is purple is ischemic area, this red is normal area. So initially there is an ischemia, but as time progresses, their infarction, irreversible necrosis starts to develop. And as time increases, this becomes more and more and may affect the entire region. And therefore, the earlier the reperfusion is done, the better it is. The time window is at the most around 6 hours, and beyond that, the benefit is much less. So the time window is really very small, and if the reperfusion is not done, then the effects can be catastrophic. If the large infarction is there, the patient is going to acute heart failure, cardiac shock, may have arrhythmias including ventricular tachycardia, ventricular fibrillation, and may have sudden cardiac death. And subsequently, if there is a large infarction, over a period of time, the heart muscle wall becomes thin and fibrosed, and LV becomes dilated, and this leads to chronic progressive heart failure. And this also produces patient to arrhythmias and sudden cardiac death as well. So we have a very small window of opportunity to prevent all these catastrophic consequences. So this is as we had mentioned, that initially days after initial treatment, those in whom reperfusion is done less than 2 hours, their outcome is much better than if the reperfusion done after 2 hours. So now the primary angioplasty is considered to be the preferred management of acute MI, because here when there is a clot and occlusion of the coronary artery, a wire is passed, over a wire a balloon is passed, and balloon is inflated to open the artery, and then a stent is placed, restoring the blood flow. This is the preferred mode of therapy. However, it is difficult. It needs a hospital setting, it needs a cath lab, it needs expert operators, it needs expert support staff. So it's a difficult thing. And on the other hand, thrombolytic or fibrinolytic therapy can be given by paramedic or nurses, and they lead to the streptokinase or the initial thrombolytic therapy. They lead to lysis of the clot and thereby opening of the artery. So now there are many trials which have shown high efficacy of the early thrombolytic therapy. These including the FAST AMI, USIC, CAPTEM, Vienna study, Prague, and Dynamic 2. So they showed that early reperfusion therapy is also very effective. This, for example, FAST AMI study, the 5-year survival follow-up was there, and as they mentioned, they did study because it is difficult to implement primary PCI in all areas. And here at 5 years, they found that fibrinolysis versus primary PCI, they were very similar. If at all, fibrinolysis was slightly better, and both were, of course, much better than no perfusion. So for multiple outcomes, it was found that the pre-hospital thrombolysis is also very good. So they found that survival is not significantly different between the two. Similarly, this is USIC registry, again pre-hospital thrombolysis in real-world settings, and there also the pre-hospital thrombolysis actually fared the best as compared to the other approaches. So we need not be apologetic about using thrombolytic therapy if it can be instituted early in patients with microinfarction. This was the CAPTEM trial, and in CAPTEM trial also the lytic therapy was showing better response in patients who did not have much delay as compared to PCI. So within the first 2 hours, or in some studies in first 3 hours, the thrombolysis actually may be preferred to primary PCI. Now this was the CAPTEM trial 5-year follow-up, and here also they continue to have the similar mortality for the primary PCI, and so the policy of pre-hospitalization for patients who present early is very good. So this is combined data of the CAPTEM and the West trial, and there also they found that the fibrinolytic therapy was showing a better response as compared to primary PCI. So in those who have get thrombolysis less than 2 hours, it is very good. So this is as the time passes, the benefit of the primary PCI becomes better. So beyond 2 to 3 hours, the benefit of primary PCI is better, but for early cases, thrombolysis is quite good. So this is the conclusion of that the early fibrinolytic therapy leads to a reduction in 1-year mortality compared to primary PCI in those who present early. And similarly, this is Prague 2 trial, another one which he had studied similar thing, and they found that up to 3 hours there was no difference between thrombolytic therapy and primary PCI. This is a Vienna STEMI registry was there, and they also found that those who had between 0 to 2 hours, within 2 hours of chest pain, thrombolytic therapy was showing tendency to have lower mortality rate than primary PCI, but this relation was inverted at those who presented late. So the idea is to get these patients quickly. Now this is a kind of graph showing also Prague 2, CAPTEM, Vienna study, less than 3 hours versus more than 3 hours. So less than 3 hours versus more than 3 hours, the results are reasonably equal. In CAPTEM it was better. So similarly in Dynamic 2, they showed overall PCI was better, but they had a subgroup predefined subgroup analysis. Less than 2 hours there was no difference, and more than 2 to 4 hours that was the main where PCI is better. So looking at this, then the people have set up various STEMI registry networks so as to get to these patients quickly and to institute fibrinolytic therapy in them so as to provide them the maximum benefit. It is with this purpose that this mission was started, and I will request Dr. Ramakrishnan to go forward.
So thank you, sir. Thank you for setting the tone. And so this is a Mission Delhi, the Delhi Emergency Life Heart Attack Initiative, where we are planning to take, or we are leveraging the technology to treat heart attacks at home. So why we need Mission Delhi? So we all know that cardiovascular disease is the most leading cause of death globally, and 85% of these CVDs are going to be because of heart attacks and stroke, and more than 2/3 of 3/4 of all the CVDs are going to happen in low and middle income countries like ours. So let me tell you, like out of the 35 lakhs STEMIs that are expected to occur in this country every year, only 25% receive thrombolytic therapy in time, and only 5% are treated with primary angioplasties in India. So nearly 50 to 75% remain untreated in a time. So ladies and gentlemen, the most common treatment for heart attack for a common garden Indian patient as of today in 2023, where India is flying India is sending rockets to Mars is no treatment. That is the unfortunate truth. So, as sir pointed out, there are two possible therapies available. Either there is a clot that has formed in the coronary artery. Either you can lyse that clot with the thrombolytic therapy, or you can open it up with an angioplasty and put a balloon and a stent. Or you can do both. So, what both helps is like you lyse the clot with the thrombolytic agent, and your window for opportunity to open the artery with the stent increases. That we call it as pharmaco-invasive therapy. So that is kind of an established method which could actually be the ideal method for a country like ours. So this graph has been shown. You can see the slope of the graph is very steep. So this is the viable myocardium once the artery get occluded, and within that 4 hours, roughly around 4 hours, whatever myocardial salvage that you can happen by opening the artery is gone. So the window of opportunity is within 4 hours. That we generally is referred to as the golden hour, which is defined as 60 to 90 minutes in general. So beyond 4 hours, the curve becomes plateau, and the amount of myocardial salvage that can happen when you open the artery is very minuscule. So every 2 hour delay, especially in the prime time, is actually leads to damage by around 40 to 60%. That leads to the adage that time is muscle and time is life in this situation. So we know how transfer happens in our country. So most of the time patients come in their own car and they are stuck in the traffic, and this is not a unique challenge to our country. This is a common challenge across the world. Getting the STEMI patient in time into a cath lab facility is a big challenge. So there are, like for example, in a Western country, there are two major challenges. So patient related delay, patient has to recognize that patient has a cardiac problem and then has to respond immediately, call 911 in US or somewhere else. And then there is a system driven delay. The ambulance has to reach, then the drug has to be, decision has to be taken, ECG has to be taken, ECG has to be interpreted, and decision has to be taken whether he goes to a primary PCA or a drug is to be given. But what happens in India? So in India, the patient delay is more. So everybody picks up a packet of Uno and start eating. I have a gastric problem, I ate something, that is why I'm having a heart attack. So that patient delay is much more, and obviously our system related delay is far more. And there is an intermediate delay that comes in new, that is delay in reporting to the right hospital. How common is that? Some of the recent registries like the HPACS registry, Himachal Pradesh registry says around 47% of patients who present with a heart attack have already reported some other first medical contact before they reach a hospital which is capable of handling a STEMI. So here STEMI refers to the major heart attack where time is critical. So in our analysis also, patients who are coming to AIIMS also, roughly around 30 to 45% of patients have actually reported to some other hospital before they reach AIIMS casualty. So this is very common. So where are we as a country as a whole? So these are the latest last 10-20 years publications from our various various registries and studies from our country. Look at the time to first medical contact. So we are talking about 2 hours and 3 hours. So our times are median are roughly around 8-9 hours is our average time, with the exception of Kerala, which is a recent primary PCA registry which showed around 4.5 median time of presentation. But rest of the country, it is roughly around 10 hours, 12 hours. And most of the time, the most common way a patient comes is own vehicle, not using an ambulance. And even when they use an ambulance, we know how the ambulance also gets stuck in the traffic. They can't reach the hospital as quickly as we want them to reach. So this is a very important slide that says what proportion of the delay is because of the patient, what proportion of delay is added by the system. So you can see majority of the delay is because of the patient's symptom onset to the contact, first medical contact, and some delay happens because of the system related delay. But most importantly, this column suggests what is the proportion of patients who don't get a revascularization. This is all patients who have reached a good tertiary care center, then also roughly around 28 to 64% don't get any treatment in time. That too, when you take a time of within 2 hours, less than 10% of Indian patients receive a treatment within 2 hours of time. So now coming back to the same graph, where are we in this graph? We are talking about a time at around 10 hours of this graph. So that means the most important thing is opening the artery is more critical than the modality of treatment. We should not be worried about whether primary PCA is superior or whether fibrinolytic therapy is superior or pharmacoinvasive is superior. But whatever way, opening the artery is more important, critical than the modality of treatment. So what we know for sure is heart attack has high morbidity and high mortality. The outcome in India are less than satisfactory. Opening the artery in time is a key goal, and thrombolysis is oftentimes, it's not a new drug. It's been there for nearly 50 years. It has been shown to be effective and it's shown to save lives, but yet only 20 to 50% of Indians receive timely treatment. So why this kind of a lesser acceptance for thrombolysis? Because the ability to do an ECG and the defibrillation are not available across the country. The trained professionals for diagnosing STEMI 24/7, 365 days in each center is not there. So non-availability and affordability of this bolus thrombolytic agent, which we'll be discussing later. And then there is a huge hesitancy of thrombolysis of non-cardiologists in the first medical centers. So these are the major issues. So one good thing that has happened is thrombolytic therapy has evolved from a streptokinase infusion to the urokinase and alteplase to a simple bolus injection. It's just a bolus, a few second push of tenecteplase and retiplase that can be given. So the advantage that has happened is the Made in India program has, some of the companies have managed to produce tenecteplase with innovative technological platform to making this product more affordable than otherwise you will be importing the drug. So what are the primary questions that Mission Delhi tried to answer? So even though primary angioplasty is considered superior to thrombolysis, even in the Western countries it is not universally available. So it's not feasible for most part of India 24/7, 365. So bolus pre-hospital thrombolytic are comparable to primary angioplasty because they are less expensive and they are shown to be non-inferior to primary angioplasty by various trials and meta-analysis, including a very famous STREAM trial. And they are preferred to primary PCI even if the transport times are longer. So the question that we wanted to establish is, can we establish an Indian model that will work in Indian conditions for pre-hospital thrombolysis? So that is the key question that we wanted to answer. I would now call upon Dr. Neeraj Parekh to talk about how it was set up.
So after the need for a pre-hospital thrombolysis setup has been explained, I will take you through the software and hardware of our pre-hospital thrombosis program. So what was the main objective of Mission Delhi program? The primary goal again was taking the heart attack care to the doorstep with a motorbike ambulance. So we can decrease the response time for heart attack patients, which is the key to the most important outcome for heart attack patients. And when we reach the doorstep, idea is to rapidly salvage those patients who are STEMI and other patients so that we can immediately institute the treatment part. And the treatment consists of all the emergency drugs like aspirin, clopidogrel, and most importantly the bolus thrombolytic agent, which we give to the STEMI patients. And also we are also upgrading the skills and education for our staff so that we can also train the trainer in future. So component one is our nerve center, that is the our command center in the OT block. These are the our nursing staff which is there to take the phone calls. There is a helpline 14430 which is available 24/7, and any call to this center is recorded. We are taking some basic questions and dispatching our ambulance. This is the again details of our command center. There are servers, all paramedics are stationed there, and our various hardware software you can see here, that is there. The doctors are available 24/7 who can read the ECG and provide instructions accordingly. This is again a complicated network chart, but again it provides a very smooth flow of work. It stores the data and also provides the software hardware integration. This is another layer where our servers are well protected. There is an ePCR software on iPads which records that ECG, transmits, and it is continuously upgraded so that we get the best of the outcomes with ECG capturing and transmission. Now the component, we can also track our hospital these mobiles like Swiggy and Zomato. You can also find out where they are and we can track them. So this is the most important component, that is motorbike ambulance. It is provided with an external defibrillator for any emergency like VT/VF. There are emergency kits. Most importantly, we have a clotbuster agent tenecteplase which is given in STEMI patients. There is an oxygen cylinder and also a portable ECG device. It's there which records and transmits ECG to the command center and to the cardiologist for their interpretation and further instructions. Now part 3, that is the delivery of patient care at spot. So whenever this patient, our staff reaches, it will take an ECG, take some questions, take a consent, and the ECG will be transmitted to the cardiologist, to the command center, and appropriate instructions accordingly will be given. If it is a STEMI patient, thrombolysis will be given if there are no contraindications, and for other patients, they will be transmitted accordingly. So what we are trying to achieve, we are trying to decrease the symptom to real time, and we will measure it as a measurable outcome. How many patients received reperfusion? How many of them received pre-hospital thrombolysis? How many of them required emergency angioplasty? What is the morbidity and mortality of STEMI both in hospital and at 6 months? And also we will analyze the cost effectiveness of pre-hospital thrombolysis. Other than STEMI patients, there are a lot of patients who will come with this chest pain, but there will be an STEMI, there will be VTVF, there will be gastric pain, colic. So we have made protocol for all kinds of situations. Even if patient is dead on arrival, or like there is some fatalities after taking consent. So all the kinds of SOPs has been made so that our paramedic can go as per the SOPs and tackle them accordingly. So this is the cute ECG machine which will record and transmit. It's there, and this is everything. So this is ECG machine. This is the EED. This is our pad which will record and transmit the ECG phone, and this is the rucksack which will have all the emergency drugs and thrombolytic therapy. Our staff is fully trained. We have collaborated with Northern Ireland Ambulance Services, which is trained for reading the ECGs, intubating, putting IV lines, giving thrombolytic agents, the basic life support, and also the advanced cardiac life support. We also collaborate with the CATs, so we have gone to the CAT centers and how to integrate our system with the CAT system and to learn from their system. So they have been trained for BCLS and ACLS. And before starting, we have done a lot of mock drills. Various scenarios has been created, and our staff has responded to this scenario accordingly, so that in case when actual life things are done, there is no scope for any deficiency. So to begin with, we started in a 3 kilometer radius around the AIIMS, which we increased in phase 2 the 5 kilometers because we were able to take more calls. This is awareness are done, the pamphlet is there, so we have distributed such pamphlets to all the RWAs, slum areas, to the small clinics which are in this 5 kilometer radius. So these are various RWAs where we contacted them, raised awareness, met most of the people, door-to-door campaigns. So what were the issues that we have to answer? The most important were medical legal issues, because this was done for the first time, whether this registration for the ambulance, indemnity for the staff, so everything was sorted out. Whether a paramedic can thrombolize without a doctor present on site, so that was also taken care of. Whether this therapy will be accepted by relatives or patients because only a paramedic is giving, there is no doctor around. Whether we will be able to deal with number of patients, there are too many calls, how will we deal with them? What are the challenges of reaching to the locations which will not be very difficult to reach? Availability of mobile networks. There were some problems initially with the networks which we sorted out, and also the quality of ECG which will be transmitted. So what we have accomplished, again, this will again over to Dr.
So sometimes what we accomplish may not be actually fully told by the numbers, because numbers don't tell you the truth all the time. But what happens is, like, some of us are driven by passion. So I tell you 2 anecdotes, because anecdotes don't make the case, but they tell you the kind of stories. Like, so I have an MD friend who did MD together, and he lives in Philadelphia, and he's a nephrologist. And on the way to his cyclodrome, he has a cardiac arrest. He's 47 at that time. He has a cardiac arrest. On the way, bystanders do CPR, and by chance, some paramedic was carrying an AED, and he was given a shock. 911 was called in the US, and then immediately he was transported into a ambulance. He was intubated in the ambulance, given multiple shocks. He was given hypothermia in the ambulance before he was shifted to a cath lab. He undergoes an angioplasty to LAD and circumflex, and we were all wondering, we were keeping our eyes crossed whether he will have a neurologically intact brain and all. So now he's currently in Himalayas. He's doing cycling. He's totally fit, and his LV function is 50%. And many of us know the other world here. So some of our colleagues also were lost across the road, had a cardiac arrest, who could not come in time, revive. We all know the stories. So I think why we should consider Indian lives as cheaper. Are our lives cheaper? So that is precisely the passion that drives this project. So because there are so many logistic and hurdles and other things, the systems we started in, say, somewhere around 2008-9 is when the prototype, the idea started. But then to get it rolling, it took us nearly some 7-8 years because of the various logistic constraints that we have to go through. So it was actually sanctioned in March 2017, but the system establishment, various struggles we had to go through for nearly 2 years before we could actually get it running. So the implementation started in May 19, and we thought we are picking up momentum. Then actually the COVID pandemic struck. So we all had a lot of difficulty in running this program, running the door-to-door campaign in the STEMI during the COVID. We all understand like how tough it was. And even if you go and attend the patient, where will the patient be transferred, and all those issues were there. So still, with all these things, we again picked up momentum once the COVID pandemic ended. Then we attended to roughly around 1,260 calls, and out of which roughly around 900 patients, 900 times we were able to dispatch a motorcycle ambulance, and roughly around 350 times we didn't because of various reasons. Most often it was beyond our geographical location, and rest of the time out of the 900, roughly around 338 were cardiac, and 487 was non-cardiac. So what over the years running, what we realized is saying something as STEMI and managing STEMI is a very important objective of this program. But the other way around, that saying that you don't have anything, you can go next day to your OPD is also a major service this program has done over the years. So then these are the various emergency calls that we attended to till November 2022. So this was roughly around 1,200. So roughly in each of the times, so we dispatched ambulances, need to dispatch ambulance around 70% of the times. Out of the things that we dispatched ambulances, we are able to get vast majority of the patients, we are able to get a ECG transmitted. When we are not able to transmit ECG, most likely we are not able to reach the patient location, or the patient refused consent, or patient already have died. So the cardiac, out of the ECG that were transmitted, roughly around 40% were roughly the cardiac problems, out of which predominantly most common problem was a non-STEMI, that is non-ST elevation myocardial infarction, where it is not so critical in time, but then they also need an acute coronary syndrome. It's also part of an acute coronary syndrome. They have to be admitted in an ICU and then managed accordingly. So they were also, this number of patients are also triaged, and then they were admitted accordingly. So all these calls we were able to attend in really quick time. So the symptom to call time, once we run such a program and we create such an awareness, that also improved. Right now we are dealing with roughly around 126 minutes. That's around 2 hours patients are able to call us on average, which is a big achievement compared to what I presented is around 6 hours to 10 hours across India. So the call to dispatch time, it has consistently come down. We are able to dispatch a motorcycle ambulance within 6 minutes, and call to patient door time is, in addition to 6 minutes, we are able to reach around 17 minutes of travel time. We are able to reach roughly in all these locations, which takes a average travel of 5.1, even though the radius means 5 kilometers, but the actual traveling time can be up to 10 kilometers. So that is the thing. So that means we are able to reach within 17 minutes any location on an average. And then within reaching that door, we are able to take an ECG within 10 minutes. So I tell you one prototype patient, we didn't pick and choose any patient. This was the last patient that we had. So this was a 60-year-old male. He had chest pain on the 9th of this month, and he had a previous history of acute coronary syndrome and a post-PCA to LAD. And there was no history of diabetes, hypertension. He was a chronic smoker, and he was continuously smoking despite having an angioplasty. And these were the vitals, like they were stable otherwise. This was the ECG. So the ECG clearly showed an ST elevation myocardial infarction with a prominent ST elevation in V1 to V4. So the ECG was taken and ECG was transmitted. ECG was confirmed at ST elevation MI. So he was given sorbitrate, aspirin, clopidogrel, atorvastatin. Upon confirmation with the cardiologist, he was given tenecteplase followed by injection heparin. So this was the ECG taken immediately after thrombolysis, 30 minutes after thrombolysis. You can see the same ST elevation that was there has settled down, that is replaced by a T-wave inversion. So we have, in fact, heart attack has been cured at home, and then ST elevation has resolved. He has become chest pain free. And most importantly, the major risk that is there while transfer and before the patient reaches a hospital is that he can have a BT and BF and suddenly die. So that risk is also taken care to some extent because we are all carrying a defibrillator, and the ECG is continuously monitored while the patient is being transferred in even an ambulance. Right? So this is the time set that we are able to achieve. So this patient has on 9th March, 11 o'clock, he has chest pain. He calls at nearly around 1 o'clock. So door time was 1:27 and consent time is 1:28, and first ECG was taken at 1:32 and needle time is 1:51. So it's a fantastic achievement to if you are able to sustainably do it across the thing. So how many patients we have treated? The total number of STEMI detected was 42, out of which the thrombolysis was not indicated because chest pain was more than 12 hours, was 7. So most of these patients we have transferred to AIIMS and they have undergone a early angioplasty. And thrombolysis was contraindicated because of either age more than 80 years or high blood pressure or bleeding or low oxygen saturation. There are 13 patients whom we didn't thrombolyze. The patients were transferred again to AIIMS and the appropriate treatment were done, and or some other hospital. So one patient refused consent. He wanted to go to some other institution, refused consent for a thrombolysis. So that patient was not thrombolyzed. Out of the 42, 21 patients were actually eligible for pre-hospital thrombolysis, and we were able to thrombolyze all the 21 patients. And then this is the data of the 21 patients we have thrombolyzed. The call to needle time was around 52 minutes, and 20 patients were shifted. One patient wanted to go to an outside hospital, and there was no mortality in the group. The other group, 17 patients were shifted to AIIMS and they were taken care, and 9 patients undergone angiography, and then there were 2 mortality in this group. So this was all the STEMI results over time, how things are evolved, and the most important thing was that we are able to manage most of these patients, accommodate these patients, and then subsequently manage with an acceptable mortality in this group. And the most rewarding thing was the time that the median time that we have taken to reach the patient, get an ECG, and give the drug. So they are well within the stipulated guideline restriction. And the most important thing is across the South Delhi, that defined area, we are getting calls. It's not we are limited calls from some particular location. So our network of awareness creation has worked, and we are getting calls across the South Delhi. And the most important advantage of this is, so we are able to reach places which are inaccessible for ambulances. And then we are able to actually, you know how the Zomatos and the other people drive, Uber people drive, Uber Eats, they drive in between your cars. So with the siren on, we are able to do much better than them. So we are able to reach the place much quickly. So this is a real life patient where we are actually given thrombolysis during the COVID time. So look at the area and how we have done this. This was happened actually. It was recreated with the patient's permission. System, so we can just get it on your tab. So it's just a bolus injection, like I say, any injection, you just inject one bolus, that's all. So the key takeaways are Mission Delhi project, as we are able to demonstrate feasibility and safety of a telemedicine supported pre-hospital thrombolysis by paramedics at patient location for the first time in our country. And we are able to demonstrate the feasibility of reaching most of these locations in the geographical area within 25 minutes of traveling 5 kilometers on most times of the day. And we are able to get an ECG and interpret the ECG within 12 minutes, come to a decision. And then we are able to administer thrombolytic therapy within 12 minutes. And more importantly, the whole thing is very much accepted and appreciated by patients and the relative, which I think we had initially our fears were there, what will happen if some untoward events happen. So we realized that creating awareness is a very important target to take it forward. So we have participated in a lot of events across over the years. These are the various events we have been part of, Mission Delhi team. I think the one thing that really worked in creating the awareness and improving the call were the auto advertisements. And then we know that the most of the primary respondents in most of these situations is the police. So they need to be primed, and they were trained in CPR also. They were primed about this whole program. This is a recurrent event that we have been doing. and they have done the CPR training programs in various schools, mohalla clinics, and various other places. And they have conducted medical camps for creating awareness. So the key learnings from this is the first organized study of pre-hospital thrombolysis in India, and we are able to establish this project. I can't tell you, but then we have to overcome a lot of operational, organizational, medical, legal, and logistic challenges. So, for example, we have to talk to the nursing council for many times before they could approve it that paramedic can give an injection in the absence of a doctor. So it may sound very stupid, but this is what it was like. So we demonstrated the feasibility and safety of a telemedicine supported pre-hospital thrombolysis at patient's location. So the major practical aims that we are able to achieve is that decrease the response times of suspected heart attack patients. We are able to rapidly triage, identify, treat, and transfer heart attack patients in a timely and consistent manner. And then we are able to definitely educate our paramedics and upgrade the skills of the healthcare provider. And this was presented in the recent American College of Cardiology as a moderated presentation. So what next? Where do we go from here? So we started off as a phase 1, 5 kilometer radius around the AIIMS, and with the same command center, we have now expanded into phase 2, again continuing the same thing around 5 kilometer radius around AIIMS. We now realize that this is more suited for a congested area like the walled city of Delhi. So where we thought GB Pant could be the nodal center, where they get the patients from walled city, where ambulance reaching may be very difficult, and then semi-urban area where the hospital density is not there, where patient cannot reach an hospital very quickly. So then we thought Vallabhgarh will be the right choice. So we have taken 10 kilometers around Vallabhgarh. The work has started, and then we will be launching it in first week of April. The dry runs and trial runs have started in March. And then then we thought we will add more sites. We have now included a control group in the phase 2, where we are identifying the patients who are coming on their own, reporting to AIIMS from this geographical area and comparing with their outcome, this outcome. So the dry run in Vallabhgarh we have started from 1st of March, and before 15th of April, we will be initiating the project in Vallabhgarh. And JIPMER, the ethical approval process is going on, and then by 1st June, we are tentatively starting. This is the 10 kilometer radius, which will be a huge area to cover. And apart from 10 kilometers, some of the dense villages also we want to cover, so that we don't miss out on anything. And we have slightly changed the model of that will suit the semi-urban area compared to the clearly urban South Delhi population. Then we have moved beyond the AIIMS. We have moved beyond the routine to a control group. And more importantly, we now thought, let us compare and care for all other cardiac emergencies. So STEMI, as I told you, is one out of the 340, only 42 were STEMI. So out of the 350 other cardiac emergencies, actually we can triage and manage before the patient is being transferred. So we have accumulated quite a good knowledge and evidence and some practical experience in managing these conditions. So let us protocolize this and make it as a program. So now we want to handle NSTEMI, that is those who do not have ST elevation in the first ECG, and then arrhythmias, acute heart failure, which is another big pandemic that is happening, and then accelerated hypertension and cardiogenic shock and out of hospital cardiopulmonary arrest. So these are various cardiac emergencies that we are planning to address. So as a department, as a whole team, we are working towards improving heart attack outcomes. One best improvement will be to prevent heart attacks. That is also we are working on. But to improve heart attack outcomes in India is a big mission for our department, out of which Mission Delhi is one part of the mission. So the other important project that we are working on is one project from ICMR that is called STEMI Act. So we identified currently 9 districts of the country. So one central hub, like for example, the Shimla Medical College has identified around 20 hospitals which are smaller hospitals to the level of district headquarter hospitals, civil hospitals and CHCs. Currently no thrombolysis happens in those places, but commonly the patient with STEMI reaches that place and they are often turned away to Shimla. So they just are traveling at least 3 hours, 4 hours before they can get thrombolysis done. So to prevent that, what we have done is again the similar app-based model we have created, where the patient's data is collected, ECG is transmitted to Shimla, and the cardiologist in Shimla says, though this is heart attack, you give thrombolysis. And the patient is thrombolized then and there and then shifted in an ambulance to Shimla. So that he gets timely treatment. So with this, we are able to actually more than double. Our aim was to nearly double it. So we are able to double the thrombolytic rate in the whole population. So this is another ongoing work from our department. And we are actually collaborating with various stakeholders from various ministry and various other hospitals to take it forward. So we have been contacted with in advanced stages with Assam. They are going to implement the same program throughout the state. UP has been have contacted us to create a similar model for UP. Meghalaya, they again have contacted us, and the Narayana hospitals are very much willing to take it forward. So ultimate aim is to have one nationwide STEMI program where every STEMI in India, we should be able to do an on-site ECG, have a central interpretation and a pre-hospital care, which may or may not include a thrombolytic care. We may use various different models for that will suit various geographies. So in this direction, we have got the SFC approval for setting up a national ECG command center. So anybody anywhere across the India can send an ECG and get an opinion from the cardiologist in AIIMS. That's the kind of center that we are trying to set up. That's a national ECG command center. And we want to now move beyond heart. The another one critical thing where time is critical, time is brain. We want to catch that. We want to have that heart and brain connection going. We want to cover it to include stroke in this heart care. And then ultimate aim is to take it to the whole country. So ladies and gentlemen, so not just pizzas, we can deliver a acute heart attack care to save life within 15 minutes.
This whole mission is brainchild of Professor Balram Bhargav, and he said, I'm sure there must be a lot of difficulties while setting up this program. I'll request him to come and tell us something.
Thank you. I just want to congratulate the entire team who have been involved in this. Thank the Honorable Director for coming and gracing. The issue, I just want to put things in perspective. Acute MI, even today, 50% die before reaching the hospital, even in Seattle, any part of the world. 50% die before reaching the hospital. Out of those 50% who reach the hospital, the mortality was 30% in the 60s. In the early 60s, it was 33%. So 1/3 would die in the hospital having reached there. Then came the CCUs, the coronary care unit in 1960s, and the beta blockers and the use of aspirin, and that fell down to about 13%. Then came thrombolysis in 77, 78. At that time, it was streptokinase, which had pre-perfusion arrhythmias, and now we have very safe bolus tenecteplase available. That reduced the mortality to about 6%, 5%. And primary angioplasty reduced it from 5% to 4%. So the difference between primary angioplasty and tenecteplase or a thrombolysis is just 1% as we speak. So I think a lot of water has flown in the last 50 years, and similar things we are learning for saving the brain and giving ruling out hemorrhage in the brain, and then finding a thrombus and giving tenecteplase bolus, wherein the artery can be opened up and strokes can be saved. So I think a lot of work has still to be done with a country which is now progressing in every which way, and with the availability of resources. I think we should be able to reach as a developed country in terms of our mortality, in our terms of our thrombolysis and primary angioplasty for our acute heart attack patients. Thank you so much.
It's really heartening to see our director, Professor Srinivas, as he has come and joined in the CGR. He has sat through the whole right from beginning, and I'll request him to kindly come and tell us something.
Don't give me heart attack.
First of all, I think we must congratulate Professor Balram Bhargav. I think we must give a big hand to him. I think that's something which is without ICMR and his this thing, I think probably it would not have happened, and the entire team also, because it's something which is there. I think charity begins at home. That we should have a dedicated space. We are planning that somehow. We should have acute coronary and the brain stroke area, present OPD area, so that we can expand our services. That's number one. Secondly, we should move forward to the rest of the country, because this is a model which has been shown here. It is working, feasibility is there, and it has the results. I think we will be a role model for country where, pizzas are delivered in 15 minutes. If it is not delivered, it is free. Then you should say that if it is not saved, then I will give you 1 million. Thank you very much.
A lot of other people have been part of this thing. Dr. Seth has been actively involved in this. Dr. Seth.
Places are doing decision finding, the internet doesn't work, but you quantitate ways of creating internet services in hotspots. From that to reaching the state where we're going to develop, going to GP1, and people from other states are coming in now. So the TV state from Assam are very hopeful that their chief minister will be grabbing this opportunity. Same with UP, Kerala. I think we're really going ahead.
Mr. Bhargav.
I would actually like to thank Dr. Chandni, who has been the mission director for the whole program. Day in, day out, and taking care of all the paramedics, how they were trained, all their training, along with the one gentleman by the name of Dr. Frank Armstrong, who just does service, comes for 15 days and trains our people every 6 months. He lives in Ireland, but he comes because of one of the Indian connection that we had there, Dr. Deepak Kapoor. So he just keeps coming in, updates the skills. They have a very nice manual which has got entire training. All that has been created right from scratch, including the equipment and the kit and everything that we created.
Any other comments, questions anyone have? So with that, we come to the end of this grand round. Thank you all very much for attending.